Welcome to Mudaliar and Menon Clinical Obstetric Lecture Series. So, today we are going to deal on with a very important chapter. It is a frequently asked short note also in your exams. Hydatidiform mole, also known as vesicular mole. Now, let's dive into this topic, hydatidiform mole or vesicular mole. Now, vesicular mole. What do you mean by the term vesicular mole? So, vesicular mole or hydatidiform moles are grouped under GTD. What is GTD? GTD stands for gestational trophoblastic diseases. So, basically, these vesicular moles or hydatidiform moles are going to be grouped under GTD, gestational trophoblastic diseases, which are pathological conditions that are going to affect the placenta. These are pathological conditions affecting the placenta due to abnormal differentiation and proliferation of trophoblastic tissue. So basically, what is the main pathology behind GTDs? There is abnormal differentiation and proliferation of the trophoblastic tissue. So this vesicular mole or hydatidiform mole are under what category? Are under, they are grouped as GTD, and these GTD is nothing but it's affecting the placenta. Due to why it is affecting the placenta? Due to an abnormal differentiation and proliferation of trophoblastic tissue. So gestational trophoblastic diseases, GTD, can be classified as benign conditions or malignant conditions. So what are the benign conditions? We have CHM, that is a complete hydatidiform mole. So a complete hydatidiform mole is a benign condition. Then we have PHM. PHM is partial hydatidiform mole. And the third one is PSN. PSN means placental site nodule. Placental site nodule. So the benign, gestational trophoblastic disease, the benign condition is mainly hydatidiform mole. You have complete and partial, and you have a placental site nodule. What are the malignant conditions? A malignant condition is an invasive mole or a choriocarcinoma or PSTT. PSTT stands for placental site trophoblastic tumor. So what are the malignant conditions in gestational trophoblastic diseases? We have invasive mole, choriocarcinoma, as well as placental site trophoblastic tumor. Now let me finish the definition. Now what is the definition? Hydatidiform mole is defined as a benign condition. A benign, I can say hydatidiform mole is a benign gestational trophoblastic disease with a malignant potential. Though hydatidiform is benign, it is a benign condition, still it has a malignant potential. That is why it's very critical to treat hydatidiform mole. So hydatidiform mole, remember, it's a benign condition but with a malignant potential. It occurs. Why does it occur? It occurs due to cystic degeneration of the chorionic villi. Very important. These terms are very important. Hydatidiform mole occurs due to cystic degeneration of the chorionic villi. Cystic degeneration of the chorionic villi resulting in death of the fetus as well as conversion of the chorionic villi into a large number of vesicles. So hydatidiform mole occurs why? Because of cystic degeneration of the chorionic villi resulting in the death of the fetus as well as conversion of the chorionic villi into large number of vesicles. Now it can locally proliferate. So hydatidiform mole can locally proliferate as well as invade the myometrium and metastatize to distant organs. See, that is why, as I told you, it has a malignant potential. So because it is having a malignant potential, it can locally proliferate, okay, as well as it can invade the myometrium and metastasize to the distant organs. If you look, incidence of hydatidiform mole is 1 per 1000 pregnancies with high prevalence in Asian countries. So all these data is not much very important, but just you need to remember the cause behind hydatidiform mole, and you need to know the malignant potential of it. Now moving on to the risk factors of hydatidiform mole. The first major risk factor is maternal age. Maternal age more than 35 years is a risk factor for hydatidiform mole. Then paternal age. Paternal age, it is also important because androgenic conceptus can result to a complete mole. Okay, so what do you mean by androgenic conceptus? So, androgenic conceptus means a fertilized egg is there, and this fertilized egg loses its chromosomes. Okay, loses its chromosomes, and then it is going to be again fertilized by, it's going to be fertilized by one or two sperms. So therefore it is having only paternal chromosomes. So an egg which is having only paternal chromosomes is known as androgenic conceptus. A conceptus having only paternal chromosomes is androgenic conceptus. So generally an androgenic conceptus usually results in hydatidiform mole. Okay, hydatidiform mole. So that is why it's a risk factor. So paternal age and androgenic conceptus will form a complete mole. And any previous history of hydatidiform mole is again a risk factor because the risk of recurrence is 0.222% after one hydatidiform mole and 15 to 20% after 2 prior molar pregnancy. So that is how the how recurrent the hydatidiform mole is. Now let's move on to the types of hydatidiform mole. So what are the types? As I already told you, there are two types. One is a complete hydatidiform mole. Next is a partial mole. So complete hydatidiform mole means the fetal blood vessels are not seen in the villi. So in the villi, if this is the villi, the fetal blood vessels are going to be not seen in the villi, and there is no evidence of existence of fetus. So what is a complete hydatidiform mole? Fetal blood vessels will not be seen in the villi, as well as there is no evidence of fetus. There is no evidence of fetus. That is complete hydatidiform mole. Whereas a partial mole, when do you say it's a partial mole? When there is a focal trophoblastic proliferation. Okay, when there is a focal trophoblastic proliferation with a cystic degeneration mixed with areas of normal chorionic villi is a partial mole. So focal trophoblastic proliferation with cystic degeneration mixed with areas of normal chorionic villi is partial mole. So what is partial mole? It is a focal trophoblastic proliferation along with cystic degeneration that are mixed with areas of normal chorionic villi. So a normal or an abnormal fetus may be present. Either, so fetus is going to be present here, and this fetus can be either normal or abnormal. So that is the difference between a complete hydatidiform mole. In complete hydatidiform mole, fetal blood vessels and fetus itself is not going to be there. But in a partial mole, focal trophoblastic proliferation and cystic degeneration will be there, mixed with areas of normal chorionic villi, and a fetus will be present, either normal or an abnormal fetus. Now moving on to the genetic basis of trophoblastic disease. So genetic basis of trophoblastic disease. So here, if the ovum is an empty ovum, okay, so here I have an empty ovum. Empty ovum means there are no maternal chromosomes at all, and it is going to be either fertilized by a single sperm, okay, with 23 chromosome, and say it is a X, 23X. So now chromosome duplication occurs, and this results in 46. What is it going to be? 46XX. This sperm chromosome will be duplicated with the empty ovum and will form 46XX. Just 46XX is nothing but it's going to be forming a complete mole. This is nothing but a complete mole. Now the next scenario is there is an empty ovum again. This empty ovum is going to be now fertilized by 2 sperms. Okay, that is dispermy. What is dispermy? The empty ovum is fertilized by 2 sperms. One is it can be either 23X or Y, or it can be either 23X or Y. Now this can result in 2 scenarios. So 23X plus 23X, okay, can be resulting in 46XX, or a 23X and a 23Y can result in 46XY. This is also nothing but a complete mole. Okay, so 46XX and a 46XY is again a complete mole. Now I am going to tell you the third scenario. This was the second scenario. The third scenario, we have 23X. This is not an empty ovum. Remember, here it was an empty ovum. Here it was, in this scenario, it was an empty ovum. But in the third scenario, what I am telling is, it is just a normal ovum with 23 chromosomes. Okay, 23X. Now, again, it can fertilize, okay, by dispermy. Okay, that is 2 sperms. So, dispermy. Okay, now this ovum can be fertilized by 2 sperms. One sperm either 23X or Y and the next sperm either 23X or Y. Now, what are the 3 possible scenarios which can occur? So, 23 plus 23 plus 23. And all 3 are X is the first scenario, that is 69XXX. 23 plus 23 plus 23 and X and Y, it's going to be 69XXY. 23, 23 and XYY is 69XYY. So these 69 either 69XXX or 69XY or 69XYY. All these are partial moles. All these are nothing but it results in a partial mole. So this is the genetic basis of trophoblastic disease. Hope it's clear to you. Now this is a very beautiful table where the differences between both complete and partial mole is given very clearly. Now let's see the difference. So this is complete mole and you have a partial mole or an incomplete mole. First, I am going to differentiate based on karyotyping. Okay, karyotyping means the genetic base. As we already studied in the previous figure, in complete mole, it can be either 46XX or 46XY. And all the chromosomes are paternally derived. What do you mean by that? Why it is only paternal origin? What is the reason? Because there is an empty ovum. Because there is an empty ovum, all the chromosomes are paternally derived and it is only paternal origin. Now moving on to incomplete mole. As I already told you, in incomplete mole there is a normal ovum. There is a normal ovum with 23X. Now this 23X can be fertilized by dispermy. Okay, one which can be 23X or Y and 23X or Y. So this is going to be resulting in triploid. Triploid means 69 chromosomes. So there are 3 kind of possibilities, either 69XXY, either 69XXX or either 69XYY. So this triploid with 69 chromosomes is nothing but is the karyotyping of partial mole. So 2 paternal sets out of just 2 paternal sets and 1 maternal complement is seen. Now tell me, out of just okay, this is x, whatever xxy and 69xyy, these two, which is involving Y chromosome, is the 2 paternal set, and whichever is xxx, this is a complete maternal complement. Therefore, it is incomplete or partial mole is paternal plus maternal origin. Now moving on to the next feature. Embryo or fetus or amnion or the fetal red blood cells. Now based on the embryo, fetus, amnion, fetal red blood cells, all of this is going to be absent typically in a complete mole. So in a complete mole, embryo will not be there, fetus will not be there, amnion won't be there, fetal red blood cells, none of these is going to be present in a complete mole. But in a partial mole, fetal or embryonic tissue are usually identified. So fetal as well as embryonic tissues are identified, as well as the fetal blood vessels and the RBCs are present. Okay, so in complete mole, both fetal blood vessels and the embryo fetus will not be there. In incomplete mole, fetal or embryonic tissues are usually identified, and fetal blood vessels and RBCs are also going to be present. Now moving on to histopathological examination. Okay. So if you look at the histopathological examination, in complete mole, there is going to be diffuse hydropic swelling. So the placenta is going to be diffusely and hydropic swelling of the chorionic villi with a diffuse trophoblastic proliferation. So in histopath, what will we see in complete mole? We will see a diffuse hydropic swelling of the chorionic villi. Okay, diffuse hydropic swelling of the chorionic villi with diffuse trophoblastic proliferation. So yeah, whereas in incomplete mole, we can see focal lesions with varying size chorionic villi with focal hydropic changes as well as trophoblastic hyperplasia. So what are we seeing in a partial mole? In histopathological examination, there is going to be focal lesions with varying sized chorionic villi with focal hydropic changes. So focal, here everything is going to be diffuse in complete, whereas in partial everything is going to be focal. So there is going to be focal lesions with varying size of chorionic villi with a focal hydropic change as well as trophoblastic hyperplasia. Okay, and the next feature is malignant propensity or the malignant potential. So for a complete mole, the malignant propensity is high, that is around 15%. For a partial mole, the malignant propensity is low, that is around 2%. Next is metastasis. Metastasis is going to be common in case of complete mole, whereas metastasis is generally non-metastatic in a partial mole. So a partial mole is non-metastatic, whereas a complete mole metastasis is common. Now let's see the histopathological features of gestational trophoblastic disease in detail. Now we are going to see the histopathological features of GTD in detail. Now first, in complete mole, see, complete mole or HYDATIFORM mole, where does the name comes from? So the appearance histopathologically as well as grossly, it looks like bunch of grape appearance. That is why it's known as a complete HYDATIFORM mole. So it is a bunch of grape appearance. And microscopically, so complete mole grossly will look like a bunch of grape appearance, and microscopically there is going to be generalized diffuse hyperplasia. As I already told you, in complete you will get everything diffuse. So there is a generalized diffuse hyperplasia. There is hydropic swelling of the villus, stroma, of varying sizes. So there is going to be hydropic swelling of the villus stroma of varying sizes. And then there is absence of fetal stromal blood vessels. So all the fetal stromal blood vessels are absent. Okay, there is, as I already told you, only in partial mole blood vessels and fetus will be present or embryo will be present. But in complete mole, fetal stromal blood vessel or the embryo will not be present. Okay, and the next feature is there is absence of an embryo. Embryo also will be absent. Fetal stromal blood vessels also absent. And nucleated fetal erythrocytes. Nucleated RBCs. Okay, the nucleated fetal RBCs. Fetal RBCs in case of complete mole is going to be absent. Okay, in the villus capillaries. So microscopically, grossly complete mole looks like a bunch of grape appearance, and microscopically there is generalized diffuse hyperplasia. Hydropic swelling of the villus stroma will be there of varying size. Hydropic swelling of the villus stroma, and absence of fetal stromal blood vessels, and absence of an embryo will be absent, as well as nucleated fetal RBCs or erythrocytes in the villus capillaries also will be absent. Now moving on to partial mole. So partial mole, what are the features, the histopathological features in case of partial mole? So first, all are going to be focal features, everything focal lesion. So there is a focal hydropic villi change and minimal trophoblastic hyperplasia. So there will be a focal hydropic villi change and a minimal trophoblastic hyperplasia. And macroscopic or microscopic evidence of fetus will be there. So fetus is going to be present or embryo is present. Fetal vessels with nucleated fetal RBCs or erythrocytes is also present. So as I already mentioned, there is going to be a focal hydropic villi change, minimal trophoblastic hyperplasia, and evidence of fetal vessels with nucleated fetal erythrocyte present. Now, what are the clinical manifestations of a hydatidiform mole? So clinical manifestation, the first manifestation is bleeding. Bleeding following a period of amenorrhea. That is important. So it's not just bleeding, but bleeding following a period of amenorrhea. First, she is going to be complaining of amenorrhea for some days, after which bleeding starts. The next is hyperemesis gravidarum. So hydatidiform mole patients can present with hyperemesis gravidarum. Then preeclampsia. Preeclampsia is a clinical manifestation. Severe anemia. So molar pregnancy. So in molar pregnancy there is going to be bleeding following a period of amenorrhea, hyperemesis gravidarum, preeclampsia, severe anemia, hyperthyroidism, disseminated intravascular coagulation DIC. Okay, and manifestations due to metastatic disease. So what are the manifestations due to metastatic disease? It can metastasize to the lung, causing acute respiratory failure, or to the brain, causing neurological symptoms such as seizures. So the clinical manifestations of molar pregnancy is bleeding following a period of amenorrhea, hyperemesis gravidarum, preeclampsia, severe anemia, hyperthyroidism, DIC, disseminated intravascular coagulation, and manifestation of metastatic disease like acute respiratory failure and neurological symptoms such as seizures. Now, first, what are you going to be identifying on general physical examination? Now, on general physical examination, the patient may be pale due to anemia. Okay, the patient may be anemic, pale and mildly anemic. So, due to, So, as you see here, due to severe anemia, there is pallor. And due to hyperthyroidism, it can present as goiter. So, patient is pale because of mildly anemic. And due to hyperthyroidism, the patient can present with goiter or enlargement of the thyroid gland. And there can be signs of dehydration in the patient, signs of tachycardia, hypotension, okay, BP low, hypotension, Molar pregnancy is generally present with hypotension and any signs of, to look for respiratory failure because of metastasis. So pale. On gender physical examination, look for pallor. For anemia, look for goiter, signs of dehydration, tachycardia, hypotension, and respiratory failure. Next, moving on to abdominal examination. So what are you going to check on abdominal examination? So on abdominal examination, the uterus may be enlarged more than the period of gestation. So uterus size, the uterus size is going to be more than the period of gestation in a molar pregnancy. Next is boggy feel of the uterus. So there is going to be a boggy feel of the uterus. Then fetal parts are not palpable. So the fetal parts are going to be not palpable and fetal heart sounds are not heard. Very important feature. So in molar pregnancy, fetal parts are not palpable as well as the fetal heart sounds are also not heard. So on abdominal examination, what will you see? The uterus size is going to be, enlarged and, usually more than the period of gestation. Boggy feel of the uterus will be there. Fetal parts are not palpable. Fetal parts will not be palpable and fetal heart sounds are also not heard. Next, on local and speculum examination. Local and speculum examination may reveal vaginal and suburethral nodules. So on local and speculum examination, what can you see? It may reveal vaginal and suburethral nodules. Next, on vaginal examination, it may reveal absence of ballotment. Very, very important. So on vaginal examination, there is going to be absence of ballotment. Ballotment of head or anything, nothing will be there because it's a molar pregnancy. No ballotment. Whereas in speculum examination, vaginal suburethral nodules can be seen. Now, how are you going to do the diagnosis of hydatidiform mole? How are you going to confirm the diagnosis of hydatidiform mole? Now, first is, if the patient has already started the process of expulsion, and vesicles are identified, the diagnosis is going to be very easy. So, suppose the patient is already started with the process of expulsion and the vesicles are identified, the diagnosis is going to be very easy. So you are going to do an ultrasound. On ultrasound, very important guys, very important MCQ also. On ultrasound of hydatidiform mole, you are going to have a snowstorm appearance. So if you look at the histopathological examination, which I already told you, this is just an image showing complete hydatidiform mole, where there is enlarged and dilated edematous villi, as well as the villi is avascular. It is known as hydropic villi, and there is increase in the cytoplast and syncytiotrophoblastic layers. That is nothing but trophoblastic hyperplasia. Okay, so if you look at this, is a ultrasound. Ultrasound showing hydatidiform mole. So it is snowstorm. See, look at this ultrasound. How does it look? It look like snowstorm or a bunch of grape appearance. It looks like a snowstorm or a bunch of grape appearance. And this snowstorm appearance is seen in the ultrasound of a complete hydatidiform mole. So it is a type of molar pregnancy where it is characterized by an enlarged uterus showing hyperechoic mass. There is an enlarged uterus showing hyperechoic mass and with multiple cystic areas without any fetal parts. So there are multiple cystic areas without any fetal part. This is an enlarged uterus. So this is the snowstorm or a bunch of grape appearance. Yeah, so we finished ultrasound snowstorm appearance, and it is important to exclude the presence of fetus, in partial mole. So in a case, so this snowstorm appearance is generally in ultrasound, and it is seen usually in complete mole. It is for complete mole. And very important, in a partial mole, presence of fetus should be excluded. Okay, it is important to exclude the presence of fetus in a partial mole. Okay, and one should look for the presence and size of theca lutein cyst of the ovaries. So one should definitely look for the size and presence, okay, presence and size of theca lutein cysts of the ovary, theca lutein cyst of the ovaries. So how are we going to do the diagnose? First we are going to do we see if the patient has already started the process of expulsion of and vesicles are identified, so that the diagnosis is easy. Do an ultrasound. If you see a snowstorm appearance, it is a mole, hydatidiform mole, and very important to exclude fetus, because if fetus is present, it's going to be a partial mole, and one should look for the presence and size of theca lutein cyst of the ovaries. Now moving on to management. Management, it starts with the pre-operative evaluation. So what will be the pre-operative evaluation? First is a complete physical examination. Then baseline serum HCG level, very important. A baseline serum HCG level should be taken to diagnose pregnancy itself. And hematologic profile is taken to rule out anemia and so on. Renal and liver function tests are done. Blood sugars, screening for preeclampsia and coagulation profile is done. Electrolytes and thyroid function tests are taken, and the chest röntgen genogram is done. Basically, röntgen is nothing but chest X-ray to rule out metastatic disease to the lung. Okay. So very important, pre-operative evaluation. You'll do the complete physical examination, take baseline serum HCG level, hematologic profile, renal liver function test, blood sugar, screening for preeclampsia and coagulation profile, electrolyte, thyroid function test, and a chest X-ray. Now the management of hydatidiform mole involves mainly two phases. Okay, so we will be managing hydatidiform moles or molar pregnancy in two phases. The first phase is going to be an immediate evacuation of the mole. So what is the first phase? Immediate evacuation of the mole. The second phase is meticulous follow-up to identify and treat gestational trophoblastic neoplasia. Okay, so the management of hydatidiform mole is in two phases. The first phase is immediate evacuation. Immediate evacuation of the, we need to immediately evacuate the mole. And the next is we need to do a meticulous follow-up. Okay, we need to do a meticulous follow-up to identify as well as treat gestational trophoblastic neoplasia. Now let's do the first one, immediate evacuation of molar pregnancy. So how are we going to do this? Before starting the evacuation process, the patient should be stabilized. That is very important. So the patient should be stabilized before evacuation of molar pregnancy. Anemia and hypertension should be definitely corrected, and the coagulation profile should be recorded. Next is suction evacuation is the treatment of choice. So what is the treatment of choice? Treatment of choice for molar pregnancy is suction evacuation is the treatment of choice in molar pregnancy. Now, after the cervix is dilated, the suction evacuation is done with a number 10 or a number 12 cannula. A safer alternative is to use manual vacuum aspiration. So MVA is much safer option. So what is MVA? Manual vacuum aspiration. A manual vacuum, but the treatment of choice is suction evacuation, and the safer alternative is MVA, which is manual vacuum aspiration. Then uterotonics. Uterotonics should be given after evacuation is complete. So after the evacuation is complete, we need to give uterotonics. Then the material obtained, okay, now the material obtained from the suction, okay, from the suction evacuation, this material should be sent for histopathological examination. And all rhesus D negative patients should be given prophylactic anti-D rhesus immunoglobulin. So all rhesus D negative patients must be receiving the prophylactic anti-D rhesus immunoglobulin. Now, what is the FIGO recommendations for follow-up of molar pregnancy? Now, this is the second phase. So, this was the first phase, evacuation of molar pregnancy. We saw the steps. First, the patient must be stabilized before the evacuation process. Anemia, hypertension should be corrected, and coagulation profile should be monitored. And suction evacuation is the treatment of choice. And with the number 10 or number 12 cannula, we can do the suction evacuation while dilating the cervix. A safer alternative is manual vacuum aspiration. So uterotonics after the evacuation is complete is given, and the material now obtained will be sent for histopath, and all rhesus D negative patients is given prophylactic anti-D rhesus immunoglobulin. So this is the first phase. Now moving on to the second phase. Second phase is meticulous follow-up. Meticulous follow-up of molar pregnancy for identifying and treatment of gestational trophoblastic neoplasia. So, there is a FIGO recommendation for the follow-up of molar pregnancy. First is, you need to do a serial serum HCG level. Very, very important. You must do a serial serum HCG level. At every visit, symptoms such as irregular bleeding, persistent cough, dyspnea, and hemoptysis should be inquired about. So at every visit, okay, at every visit, the symptoms such as irregular bleeding, okay. So at every visit, the symptoms such as irregular bleeding and persistent cough, dyspnea, these are all to rule out metastasis, okay, to the lungs. Persistent cough, dyspnea, and hemoptysis, irregular bleeding. At every visit, we need to inquire, okay. Every visit, we need to inquire about all these features. Then pelvic examinations should be repeated every 2 weeks. So, every 2 weeks we have to repeat pelvic examination in these patients, okay, while doing follow-up. And chest row end genograms. Chest row end genograms, like chest x-rays. Chest row end genograms should be performed to detect pulmonary metastasis. So what are the FIGO recommendations for follow-up? First, we need to do serial serum HCG levels, and at every visit we need to look for all the features of bleeding, dyspnea, cough, hemoptysis, and every 2 weeks we need to do pelvic examination, and chest roentgenograms should be performed to detect for pulmonary metastasis. Now, follow-up after evacuation of molar pregnancy is very important. So, molar evacuation is done. After molar, so how are we going to do this follow-up after evacuation of molar pregnancy? So, molar evacuation is done. After molar evacuation, beta HCG should be monitored after 48 hours of evacuation. So, after 48 hours of evacuation, beta HCG must be monitored. Then, weekly until 3 negative values. Okay, we need to follow up weekly until there are 3 negative values, and then monthly for 6 months. Every month for 6 months we need to monitor. Monthly for 6 months. Okay. So molar evacuation, beta HCG after 48 hours of evacuation, weekly until 3 negative values, and then monthly for 6 months. Now moving on to the contraception. Contraception following molar pregnancy. So how are we going to how is going to be the contraception following molar pregnancy? Now, until the beta HCG levels are normal, very, very important, until and unless the beta HCG levels are normal, the barrier method of contraception is the ideal choice. So what is the ideal choice? Ideal choice is, first we need to look at the beta HCG. Okay, whether we need to check whether beta HCG levels are normal. So until and unless the beta HCG levels are normal, okay, the ideal choice is going to be barrier method. So what is the ideal choice? Barrier methods is the ideal choice. Now once, okay, this is until beta HCG is normal. Now if the beta HCG becomes normal, now beta HCG has become normal. Now what should we do? Either combined oral contraceptive can be given, okay, either combined oral contraceptive can be given, or intrauterine contraceptive devices can be used. So either combined oral contraceptive devices or intrauterine devices can be used. Okay, now moving on to gestational trophoblastic neoplasia, GTN. So how are we going to identify and treat GTN? Now GTN can develop following the evacuation of a molar pregnancy, or it can develop after a non-molar pregnancy, abortion, ectopic pregnancy, or live birth. So GTN is very common. It can develop either following an evacuation of a molar pregnancy, or it can develop after a non-molar pregnancy or abortion, ectopic pregnancy, or a live birth. Approximately half to 2/3 of GTN cases follow molar pregnancy. Very, very important. So gestational trophoblastic neoplasia cases, okay, around half to 2/3 of cases, okay, 2/3 of cases are going to be arising as a follow, okay, as it is following the molar pregnancy. That is why after evacuation of molar pregnancy, it's also important to identify and treat molar pregnancy in phase 2 management. Now let's look at the criteria for diagnosis of post-molar gestational trophoblastic neoplasia. So what is the criteria for post-molar gestational trophoblastic neoplasia? First is when the HCG levels plateau over a period of 3 weeks or longer. Okay, when the HCG levels plateau over a period of 3 weeks, okay, or longer, like days 1, 7, 14, 21, and when there is a rise in HCG of 10% or greater for 3 consecutive weeks, day 1, 7, 14 and 21, there is elevated HCG level 6 months after evacuation. Okay, after evacuation and 6 months later, there is elevated HCG levels, then we need to diagnose postmolar gestational GTN. And if there is histologic diagnosis of choriocarcinoma, placental site trophoblastic tumor, or invasive mole, appearance of metastasis. All these are criteria to diagnose postmolar GTN. So the spectrum of GTN includes the following. So the spectrum of GTN includes the following. There are 3. First is invasive hydatidiform mole. It can be choriocarcinoma or can be placental site trophoblastic tumors. So it can be either invasive hydatidiform mole, choriocarcinoma, or a placental site trophoblastic tumors. Now first coming to invasive hydatidiform mole. So invasive hydatidiform mole, the pathological features of a complete hydatidiform mole will be there in invasive hydatidiform mole. So invasive hydatidiform mole is basically malignant and it shows all the pathologic features of a complete hydatidiform mole. So why it is known as invasive? Why it is called as invasive? Because there is invasion to the myometrium as well as the venous system. So because this hydatidiform mole is invading into the myometrium and the venous system, it is known as invasive hydatidiform mole. Metastasis can occur to lower genital tract as well as to the lungs. So metastasis can be to the lower genital tract as well as to the lungs. Rupture of the uterus, okay, very important. Rupture of the uterus leads to massive intraperitoneal hemorrhage. Rupture of uterus leads to massive intraperitoneal hemorrhage, and microscopically the villi pattern is going to be maintained. So villi pattern will be there. So this is the all about the invasive hydatidiform mole. Next, moving on to choriocarcinoma. So choriocarcinoma, macroscopically if you see choriocarcinoma, the tumor is bulky with hemorrhagic and necrotic area. Okay, if you look at macroscopically, the tumor will be bulky with some hemorrhagic as well as necrotic areas. This choriocarcinoma can be found in tubes, ovaries, lung, liver, spleen, kidney, bowel or brain. And microscopically, cytotrophoblast and syncytotrophoblast elements, okay, are going to show varying amounts of pleomorphism and aplasia with areas of hemorrhage and necrosis. So microscopically what you can see is cytotrophoblast and syncytotrophoblast elements will be there with varying amounts of pleomorphism and aplasia with definitely areas of hemorrhage and necrosis. Then the chorionic villi are going to be absent. Okay, all the chorionic villi is going to be absent even at the primary uterine sites of the disease. So choriocarcinoma macroscopically we can see a bulky tumor with hemorrhage and necrotic areas. It's found in many places like ovary, tube, lung, liver, spleen, etc. Microscopically we can see varying amount of pleomorphism, aplasia in the cytotrophoblast, syncytotrophoblast with areas of hemorrhage and necrosis. The chorionic villi will be absent even at primary uterine sites of the disease. Next, moving on to the third one, that is placental site trophoblastic tumor. So the third one is placental site trophoblastic tumor. So placental site trophoblastic tumors should be considered to be locally invasive with a low malignant, okay, there is low malignant potential because a minority of patients will develop extrauterine metastasis. So placental site trophoblastic tumor should be considered to be locally invasive with a low malignant potential because a minority of patients will develop extrauterine metastasis. So what are the investigations that are to be done to determine the prognosis? First is detailed history and physical examination. Next is pelvic examination, especially to look for the labia, the vaginal as well as the suburethral nodules. Okay, and complete blood count, liver as well as renal function test, coagulation study. Now I think you will understand why you need to take liver and renal function test, because choriocarcinoma can invade into liver, spleen, kidney, bowel, brain also. That is why you do liver renal function test, coagulation studies, immediate pre-treatment serum beta HCG values, sonography. In sonography you need to look for the pelvis as well as the abdomen. Then chest x-ray to look the number of the lung metastasis, CT chest, CT MRI of abdomen and brain, CSF analysis. So these are all the investigations that are done to determine the prognosis. So GTN, gestational trophoblastic neoplasia, there are 4 stages. Stage 1, Stage 2, Stage 3, Stage 4. Stage 1, what is the description? Disease is confined to the uterus. If the GTN, if the disease in GTN is confined to the uterus, it is stage 1. If GTN extends outside of the uterus, but is limited to the genital structures. What are the genital structures? The adnexa, vagina and the broad ligament. Okay, so GTN is extending outside the uterus but is limited to the genital structures, that is the adnexa, vagina and broad ligament. That is stage 2. What is stage 3 then? GTN extends to the lungs. If the GTN extends to the lungs with or without known genital tract involvement, okay, with or without known genital tract involvement, but when GTN extends to the lungs, it is stage 3. And when it reaches all the other metastatic sites, all other metastatic sites means it is stage 4, like liver, renal, brain, that will be spleen, all will be stage 4. Stage 1, confined to the uterus. Stage 2, it extends outside to the uterus but limited to the genital structure. Stage 3, GTN extends to the lungs. Stage 4, other metastatic sites. Now moving on to the management of GTN. So the management of GTN, in the management, the prognosis of the patient with GTN can be calculated by the FIGO prognostic score in combination with anatomical staging system. So this is the modified WHO prognostic scoring system. Okay, and if you see, the scores are 0, 1. So the scores are 0, 1, 2, 4. Okay, so if age is less than 4, it's 0, and more than 4, it's 1. Antecedent pregnancy, mole, it is 0. Abortion, 1. Term, 2. So that's how this goes. So based on this WHO prognostic scoring system, we can classify them as low risk. Low risk means the score is 0 to 6. High risk means the score is more than or equal to 1. So 0 to 6 is low risk. Okay, and more than or equal to 7 will be high risk. So age, antecedent pregnancy, whether mole, abortion or term, interval months from, okay, whether it's less than 4, 4 to 6, 7 to 12, more than 12, pre-treatment serum HCG levels, okay, if it is less or more, largest tumor, the tumor size and site of metastasis, especially liver, brain, very high, the prognosis is very poor, okay, and number of metastasis. Based on all this, we are going to classify into these low risk or high risk, and we are going to treat each of the risk particularly. Now, management of low risk disease. So coming to the management of a low risk disease, a single agent chemotherapy with methotrexate, either methotrexate or actinomycin D, is the treatment of choice for these patients. Okay, now so how am I going to manage low risk? So low risk, it's going to be a single agent chemotherapy. Either I can give methotrexate, or I can give actinomycin D. So this is the treatment of choice for low risk disease patients, low risk GTN. So actinomycin D is approved for the patients who are resistant to methotrexate. Methotrexate is the best. Okay, methotrexate is the best, and actinomycin D will be given only if the patients are resistant to methotrexate. Okay, and the dose of will be 0.5 mg intravenously, 0.5 mg intravenously for 5 days every 2 weeks. Okay. Now, if you look at the methotrexate agent, the regimen is going to be 50 mg intramuscularly. When and all you should give 50 mg intramuscular should be given on day 1, day 3, day 5, day 7. Okay. And frequency is going to be bi-weekly repeated. Okay, so bi-weekly it's going to be repeated. Bi-weekly it will be repeated as on day 1, 3, 5 and 7. Folinic acid 15 mg 30 hours, okay, after each methotrexate given. So folinic acid, as you already know, to reduce the methotrexate toxic effects or side effects or toxicity, we are also going to give along with folinic acid. So folinic acid should be given 30 hours after each methotrexate injection, again bi-weekly repeated, 15 mg per oral. Now let's move on to the management of high risk GTN. So high risk GTN, on day 1 I will be giving etoposide. Etoposide is 100 mg per meter square infused over 30 minutes. Actinomycin D is 0.5 mg IV bolus. Methotrexate 100 mg per meter square IV bolus. And on day 2 I am going to give etoposide 100 mg per meter square infused over 30 minutes. Actinomycin D is 0.5 mg IV bolus. And instead of methotrexate, I will be giving Folinic acid. Okay, folinic acid 15 milligram intramuscularly every 12 hours for 4 doses beginning and 24 hours after starting methotrexate. 15 milligram IM every 12 hours for 4 doses beginning beginning 24 hours after starting methotrexate. Next, on day 8, I will be giving cyclophosphamide. Cyclophosphamide, the dose is 600 milligram per meter square IV infusion. And then vincristine, that is 1 milligram per meter square bolus. So the main etoposide on day 1 and day 2 will be given. Actinomycin D day 1, day 2 will be given. And day 1 along with it methotrexate is given. On day 2, instead of methotrexate, folinic acid will be given. On day 8, cyclophosphamide and vincristine will be given. So this is the flow chart showing the optimum treatment of gestational trophoblastic neoplasia. If you look, gestational trophoblastic neoplasia first is going to be divided as non-metastatic and metastatic. That is the first classification. If it is non-metastatic, then I will give a single agent chemotherapy, that is methotrexate or actinomycin D. Only to patients who are resistant to methotrexate, I will be administering actinomycin D. And metastatic. Now metastatic, I am going to classify them as low risk, that is less than or equal to 6. High risk, that is more than or equal to 7. So low risk means, again I will be giving a single agent chemotherapy involving methotrexate and actinomycin D. In case of high risk, more than or equal to 7, okay, there is a multi-agent chemotherapy. This multi-agent chemotherapy, the mnemonic is EMA-CO. Okay, very important. What is the multi-agent chemotherapy? EMA-CO. E for etoposide, M for methotrexate, A for actinomycin D, C for cyclophosphamide, O for oncovin or vincristine. So for high risk, how am I going to treat? Multi-agent chemotherapy, EMA-CO, E for etoposide, M for methotrexate, A for actinomycin D, C for cyclophosphamide, O for oncovin or vincristine. Now, how am I going to follow up the patients with gestational trophoblastic neoplasia? Now, again, follow up will be divided based on low risk patients or to high risk patients. For low risk patients, how will I follow up? Serum beta HCG weekly, okay, till there are 3 negative values. And on 1 cycle of chemotherapy after the last normal value and beta HCG monthly for a year. Okay, that is in low risk. So low risk, how am I going to follow up? GTN serum, weekly serum beta HCG level should be taken and there must be at least 3 negative value and 1 cycle of chemotherapy after the last normal value must be given and beta HCG monthly for a year. Okay. And now moving on to high risk. High risk patients, serum beta HCG weekly again, where till there are 3 negative values again. And there must be, instead of 1 cycle of chemotherapy, there must be here 2 to 3 cycles of chemotherapy after the last normal value. Okay. See, in low risk patients, after the last normal value of beta HCG, we are going to give only 1 cycle of chemotherapy. But in high risk, after the last normal value of beta HCG, we are going to do 2 to 3 cycles of chemotherapy. In low risk, beta HCG is going to be again repeated monthly for a year. Whereas in high risk, beta HCG is monthly for 2 to 5 years. Okay, this is only beta HCG monthly only for 1 year. But here in high risk, beta HCG should be sample should be taken monthly for 2 to 5 years. For 2 to 5 years. Okay, followed by yearly beta HCG lifelong. So after 2 to 5 years, monthly early beta HCG lifelong should be taken yearly. Okay, every year. Patient should be advised contraception during follow-up only. Okay. So what are the contraception during follow-up that the patients should be advised of? Oral contraceptive pills are safe. Not barrier methods, but oral contraceptive pills are safe. So we have come to this topic hydatidiform molds. We have covered everything in detail as well as GTN and the diagnosis and management of GTN. So hope you like this video. So to see and watch more videos on this Mudaliar Menon lecture obstetrics series, and to watch more videos on obstetrics and gynecology and other final year topics, please do like, subscribe and share this channel. Thank you.